severe breathlessness with the following ABG. pH is 7.20, PaO2 is 48, PCO2 is 78, bicarbonate is 18. The interruption from the findings is respiratory acidosis with hypoxia with metabolic acidosis. Since the patient is a chronic smoker, this could be because of the he has since a patient is a chronic smoker, my diagnosis will be acute exacerbation of COPD. So COPD is a progressive airflow limitation that is not reversible. Acute exacerbation of COPD is defined as change in the patient's baseline with dyspnea, with increased sputum and increased cough production that is beyond day-to-day variation. So initially, I'll ask for the presenting complaints. If the patient has a history of cough with the sputum, with sputum, I'll ask for any color changes from white to yellow. And if the sputum is foul smelling, if there is any blood stain, and if there is any positional change with increased production of sputum. And then I'll ask for history of fever, and then history of breathlessness, which he has come with. And then I'll ask for past history of ICU admission, that is exacerbations, again previous history of exacerbations, ICU admissions or mechanical ventilation, and a history of smoking, and any past history of asthma, TB, and then any associated comorbidities like hypertension, diabetic, and coronary artery disease. And if you have any recurrent active infections, yeah, and then any past surgical history. And then I'll ask for any past history of family, any past family histories like COPD or asthma, and then allergic history. And then coming to physical examination, I'll first look for pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. And then going into systemic examinations, in RS examination, I'll look for the bilateral air entry if there is any associated V's or rhonchi, and then I'll look for I'll see if the chest is symmetrical, and if the patient and they are coming to CNS, if the patient is alert, conscious and oriented. In case of CVS, I'll look for any murmurs. In GA, I'll look for any abdominal distension. And then systemic examination, systemic signs, I'll look for neck vein enlargement, and then cyanosis, peripheral edema, and if there is any loss of muscle mass. Coming to investigations, I'll ask for CBC, where mainly a total count to rule out any infection, total count and differential count, and then HB to look for polycythemia or anemia. And then I'll ask for chest X-ray to see any emphysematous changes or consolidation. And I'll ask for ECG to look specifically for any right ventricular hypertrophy or right axis deviation. And then echo to look for any LV dysfunction or right ventricular dimension or signs of pulmonary hypertension. And then usually in COPD patient will ask for pulmonary function test, and then ABG. And coming to management, in acute exacerbation of COPD, we have drug management with drugs, and then non-invasive ventilation, and then invasive mechanical ventilation. In drug therapy, drug regimens that is used in acute exacerbation of COPD is albuterol, which is the first-line bronchodilator beta-2 agonist of 2.5 to 5 mg by nebulizer, or 2 to 8 puffs will give, or levosalbutamol, the dose of 1.2 to 2.5 mg, which is also by nebulizer, or 2 to 8 puffs. And then we can combine it with ipratropium bromide, which is a dose of 0.5 mg by nebulizer, again 2 to 8 puffs. And then we can add corticosteroids of 30 to 40 mg prednisolone per oral, or we can give IV methylprednisolone. And then we can go for antibiotic therapy, which is more likely to improve clinical outcomes in COPD exacerbation. The most common bacteria involved are Streptococcus pneumonia, Pseudomonas, Haemophilus influenza. It could also be a viral infection. And And then coming to NIV, which is the non-invasive ventilation, is the first line and standard of care in COPD with acute respiratory failure. The goal of NIV is to reduce the work of breathing, prevent asynchrony, and optimize the patient comfort. So with NIV, there will be unloading of respiratory muscle usage. So there will be decreased fatigue and decreased work of breathing. And then NIV also improves the gas exchange, and it improves the alveolar ventilation. It decreases dynamic hyperinflation, and it also decreases the prolonged hospital stay and reduces the pulmonary complication, which is seen more with the invasive mechanical ventilation. The target of NIV is tidal volume of 6 to 8 ml per kg, respiratory rate is 25 to 35 per minute without dyspnea or distress, FiO2 to maintain the SpO2 of 88 to 92%. And then the absolute contraindication of NIV is respiratory arrest, cardiac arrest, facial trauma or injury or burns, or fixed upper airway obstruction. Relative contraindications include hypotensive shock, uncontrolled cardiac ischemia, uncontrolled copious GI bleed. The patient is agitated and uncooperative, unable to protect his airway, swallowing impairment, and recent upper airway or GI surgery. Coming to invasive mechanical ventilation, indication includes NIV failure, severe hemodynamic instability, life-threatening respiratory failure, respiratory or cardiac arrest, failure to oxygenate, that is persistent hypoxemia, failure to ventilate, that is acidosis, unresponsive to non-invasive ventilation. And goals of invasive mechanical ventilation in COPD is to minimize the dynamic hyperinflation and air trapping, which in turn will reduce the work of, and to avoid over distension of alveoli, and for the adequate over distension of alveoli, and for adequate ventilation and adequate oxygenation. Objectives of mechanical ventilation is reduction of dynamic hyperinflation and air trapping, which is achieved with bronchodilator and appropriate ventilatory settings, including long expiratory time, high inspiratory flow, low respiratory rate, and titration of PEEP. And then adequate gas exchange, that is low oxygen mixture, since hypoxic drainage drives main mechanism to maintain the adequate ventilation perfusion. And then prevention of lung injury, to prevent a ventilator-induced lung injury. So tidal volume as low as 5 to 7 ml per kg is advised. And to decrease the respiratory muscle fatigue, we can use 24, at least minimum of 24 to 48 hours of sedation. And then we can allow permissive hypercapnia of pH up to 7.2 in case of COPD patients. That's also.
Okay. Now you mentioned the same tidal volume, respiratory rate and all in NIV also.
Sir, in NIV, it was 6 to 8 ml per kg, sir.
So in
ventilator
NIV, do you have a facility to set the tidal volume? So if the patient is continuously.
No, sir. As in the target that we achieve with the NIV usage, sir. We'll adjust the PEEP and pressure support, sir. The target that is achieved with the usage of NIV.
More about the IAPP and EPP. It is inspiratory positive airway pressure and expiratory positive airway. Of course, this is a question to check whether you have any knowledge of managing an acutely ill patient in the critical care unit. So this question is mainly to get your knowledge about management of the acutely ill patient in critical care. It is not a question for any anesthesia purpose. So you have to first define. Of course, you mentioned that this ABG shows that patient is in both respiratory acidosis and metabolic acidosis with hypoxemia. Do you require any other information on that apart from this pH, PaO2, PCO2 and bicarb alone? Do you require any other information from the ABG report?
Other electrolytes.
You have to, when you know that bicarb is low and there is a possibility of metabolic acidosis, you must know whether it's an anion
Anion
gap. How
gap.
much is the
Yes,
anion
sir.
gap? Isn't it?
Yes,
So
sir.
that
Yes,
has
sir.
to be mentioned in your answer. I would like to
Okay.
know whether the patient has a normal anion gap or high anion gap acidosis along with the other. Now, what type of respiratory failure this patient is in?
They have type 2 respiratory failure, sir. Hypercapnic
Hypoxic,
respiratory.
hypercapnic
Hypercapnic
respiratory failure.
respiratory.
What are the causes of hypoxia, hypoxemia?
Sorry, sir.
What are the causes of hypoxemia? Hypoxemia or low PaO2?
Sir, here in COPD patient, it is because of
No,
PQ
generally,
mismatch.
what are the common causes of hypoxemia?
So decreased inspired fraction of oxygen, sir.
Okay, is that the main cause? In
Uh,
spite of giving oxygen, can you have hypoxemia? Some patients continue to be hypoxemic with a low PaO2.
with PQ
When
mismatch
there
and
is
shunting.
diffusion problem also, there will be hypoxia,
It
sir.
can be diffusion problem, it can be leaking
PQ
mismatch,
mismatch
or
and
it can
shunting.
be shunt. This is very
Yes, sir.
important. Shunt fraction, if the patient has a shunt, then however much you increase the FiO2 of the hypoxemia will never get corrected. For example, a phalangopalas tetralogy, where there is a right to left shunt. Giving 100% oxygen, will it improve the PaO2 and saturation?
No, sir.
It will not. Okay, so first thing is you must know what you must identify what is the cause of hypoxemia in this, whether it is secondary to hypercapnia or whether it is primarily hypoxemia. And here only clue you have is he is a chronic smoker. So you have imagined that he is a known COPD patient and he has now landed up with an exacerbation. That is quite a good guess, a normal clinical guess that is there. But what are the other differential diagnoses which can result in the same picture of acute breathlessness? Supposing he
Pulmonary
doesn't have any previous COPD, what are the other causes which can result in an acute breathlessness in a patient?
be pulmonary edema, pulmonary edema, sir, and pulmonary embolism.
More common than that,
Pleural
70 years
effusion.
old, pleural effusion.
Pleural
It
effusion.
cause such an acute pulmonary breathlessness. Pleural effusion is usually a chronic one. Slowly collect. Aspiration.
Pneumonia, sir.
Okay.
Aspiration and pneumonia. A 70 years old person, you have to think of silent aspiration and pneumonia rather than the exacerbation. If he denies that he has never been a COPD patient, he has never taken any bronchodilators except for his smoking, he has been going around happily. The other important differential diagnosis you have to think of is aspiration and pneumonia. And even without obvious overt aspiration, elderly patients are quite prone for silent aspiration and developing pneumonia, which ultimately lands them up with an acute picture of breathlessness. So that also has to be taken into account. So if this patient is received in ER, your description should go such a way that if such a patient with history of chronic smoking, 70 years old, with an ABG value indicative of type 2 respiratory failure with both metabolic acidosis also being present. If he comes to ER, what are you going to do first?
Sir,
It's better to
first,
discuss the answer in that way rather than assuming that he is a COPD patient with an exacerbation. What is the first thing you will do?
sir, first we'll check for the vitals, sir.
Excellent. First and foremost, check for the vitals, measure the hemodynamic status, assess the hemodynamic status, whether he has got any hemodynamic instability. Very good. Then what do you do next?
First, we'll assess the hemodynamic status, and if the saturation is low, we'll supplement him with the oxygen. And if the BP is on the lower end, we'll supplement with fluids, sir. and we'll check if he has shown any improvement with the oxygen, so if the saturation is increasing or not.
Mhm.
If he is not increasing, if it's not increasing, then we'll think of other methods, sir.
Understood. Right. So that is how you immediately, that is how you admit him in ICU and then start treating him with all your regular methods of improving the oxygenation as well as removing the carbon dioxide. In case he says he has a earlier history of COPD, then what is the precaution you have to exercise in reducing the hypercapnic state?
Sir, precautions is we have to will try not to diminish his hypoxic drive, sir. So
Very
we'll
good.
keep the FiO2 as low as possible
Ah.
till he maintains his saturation.
You mentioned one particular terminology, permissive hypercapnia. You need not bring it back to 40 plus or minus 5.
Normocapnia, yes, sir.
You need not aim for normocapnia in these patients if he has got a previous history of chronic obstructive pulmonary disease. So you can allow for a permissive hypercapnia up to 55 millimeters of mercury. So from 78, even if it comes to 55 and clinically patient is improving, then that is the state which is maintained rather than trying to wash out all the carbon dioxide and taking to a normocapnic level of 40 or less than 40. Okay, that may suddenly make him go in for acute respiratory arrest and complicate the issues more. Okay? So that
Yes,
is
sir.
the important thing that we have to think. So the choice for improving the ventilation in this patient are two. One is non-invasive, other is invasive. In the non-invasive, as you rightly mentioned, all the contraindications and indications you select that and then choose the appropriate inspiratory positive pressure and expiratory positive pressure and see whether whole thing improves. And then if the patient is not improving with that after a particular time, then you have to go for
Invasive
mechanical
mechanical
ventilation by
ventilation.
invasive ventilation. So you have to do a intratracheal intubation. What are the challenges in putting the patient on invasive ventilation in these type of patients?
Sir, invasive ventilation with the PEEP, we might trigger barotrauma, sir, since they
Very
already
good.
have,
Is it
and
easy
they
to
all,
wean these patients once you put the patient on intubation and ventilator, a COPD patient?
no, sir.
Weaning will be a problem. Okay, they may
Yes,
go
sir.
on for months and weeks. By the time you try to maintain this ventilation, you may have to use sedation and paralysis, which may lead on to what other complications?
Sedation and paralysis.
Hmm. What are the long-term complications of sedation and paralysis in ICU patients? Sedation again takes
Muscle
away
weak.
the respiratory drive or it maintains it?
Atrophy of muscles, sir.
Okay, of
Long-term
muscle.
prolonged ventilation.
Uh, So they may develop polyneuropathy of long-term ICU stay. And post-traumatic stress disorder also will be there. They may go in for nutrition-related problems. So all these things have to be discussed in this because they ask you specifically about ICU management of this patient. So the internal intraoperative management, methods of ventilation, if necessary to put on invasive ventilation, the challenges, the difficulties in weaning, modes of trying to wean the patient, and then the post discharge problems, all these things have to be addressed in your answer. Okay?
Yes, sir.
Investigation, how to do that.